It's really, this session is designed for those of you who maybe haven't learned a lot about what pragmatic trials are, need a little bit of an introductory session here. And so, so Megan will be telling us a lot about, well, what is a pragmatic trial? What do we even mean? What are we talking about? Megan Branda is a senior research instructor in the Department of Biostatistics and Informatics at the University of Colorado School of Medicine. She's planned and managed clinical trials for over 15 years. It's tremendous to have you here, Megan. She's been a member of 3 national cancer cooperative groups by planning and analyzing phase 1 to 3 randomized clinical trials. She supports research endeavors at the Mayo Clinic's KER unit by collaborating on the design and analysis of practice-based interventions, as well as pragmatic clinical trials. She's associate editor for the Trials Journal, as well as the instructor of a graduate course on clinical trials design here at the University of Colorado. With that, I'll turn it over to Megan.
Thank you, Bethany. All right, I'm gonna share my screen. And let's see. Do you see the slide view or do you see the presenter view?
We see the presenter view.
All right, I'm gonna switch it. So you just see the slides.
Perfect, that's good.
Thank you so much for attending today. So as Bethany mentioned, this is kind of like a pragmatic trials 101. Just a view into the rationale behind them and in the process for real world interventions. So starting out basic, what is a pragmatic trial? The definition by Rowland and Torgensons in 1998 was pragmatic clinical trials seek to determine the effectiveness of an intervention in a real-world setting to inform clinical decision-making. Sachs in 2016 said pragmatic trials are intended to help typical clinicians and typical patients make difficult decisions in typical clinical care settings by maximizing the chance that the trial results will apply to patients that are usually seen in practice. PCORI came out with their own definition that pragmatic clinical studies aim to provide research results that better reflect everyday healthcare in a wide range of patients. Traditionally, clinical studies test how well treatments or other care approaches work under ideal conditions with carefully selected patients. So what do we have here? We have 3 definitions that kind of are using these terms of real world, typical, everyday healthcare. They're all inferring that what we do in our day-to-day practice within our clinical trial work is not representing everyday care, right? So where does this impression come from, and is it actually true? This is a clip from a series of articles in the Journal of Clinical Epidemiology. They did a 7-part series on pragmatic clinical trials. And so what you see here on the left-hand side of your screen is what we kind of imagine when we're thinking of efficacy trials. So when we say an efficacy trials, is the trial doing what we intend to do for the intervention of interest? So if we have a medication trial, does it lower the blood pressure that we designed the medication for? And so we aim for those trials is to try to understand, does it work for its intended purpose? And so they try to get this kind of homogeneous population recruited to understand truly, does it do what it's intended to do? Whereas within the practice that we're seeing on this left-hand side, we have a more diverse population, a heterogeneous population that we see in everyday practice. Sorry, my views are all blocked. One second. So within these, thinking of this previous slide's definitions, pragmatic trials allow for better understanding how interventions work amongst these patients. What does this all mean? Well, I'm going to try an analogy here. Let's see if it helps. So you want to make a new meal, right? You've never made this meal before. Nobody's ever made this meal before. So when you first are going to make it for the first time, you're not going to buy enough ingredients to cook for 50 people, right? You're going to start out with a small portion just to see, is it even edible? Is this feasible? Can I make this meal? This is within the clinical trials world, this is your pilot trial. Can I recruit the patients? Can the intervention actually go within the practice itself? How does consent process going to work? So forth. That's your pilot trial. Now that you've tried it out, you know that the food is edible, you're going to go on to your next stage. Do the people of interest that I care about, maybe your family, your children, your spouse, your friends that you have dinner group with once a week, will they eat it? Do they enjoy it? And your primary outcome there is that, for instance, your children will eat it without whining and nobody gets sick. This is your efficacy trial. For your everyday practice, does this actually do what it's intended to do? All right, let's expand even further. So we have this wonderful meal, our family eats it without complaining. We're going to move on now to, I can do this in a larger scale. This is such a great meal, everybody should have it. So now I'm going to have the family reunion dinner, or maybe it's going to expand into a restaurant. Our thought process on how we do it, we know what our family wants to eat. We know how they like it. We can gear it towards that. We know it works. Well, now if we're expanding it to a much larger population, we need to kind of rethink on how we're going to offer this. What's the kitchen like that we're going to be cooking the meal in? Is people going to be standing or sitting while they're eating? Aunt Kathy has specific dietary needs that I need to incorporate. And so this is where your pragmatic trial comes in. You need to evaluate your intervention and how to make it work within that new setting. So where did this idea of pragmatic trials come from? There's a key article from 1967 where Schwartz and Lelouch proposed that the efficacy or explanatory trials are insufficient in that their goal is to assess the efficacy of the two interventions, focus on the treatment working, on the key clinical outcome of interest, and under a key specific level of optimization. We're trying to do it with adherence to the intervention, truly patient populations that don't have any contraindications or any kind of other medications that might kind of muddy the waters per se. And so the efficacy or explanatory trials aimed at understanding. The gap that they proposed was that the cost or burden or trade-off amongst a more, the knowledge within that thing, the cost and the trade-off is missing among a heterogeneous population under unideal settings. So the information needed to help the clinician and the patient make informed decisions of which the decision may not be based on what just the primary clinical decision. So thinking about patients that are choosing to have an intervention, their decision may not just be, my blood sugar goes down, can I do my everyday life activities? Will this affect my dietary? I love to cook. Will this impact how I live my life? And so expanding that kind of knowledge and understanding. Why do we need these trials? So from the proposal of the pragmatic trials in 1967 to more recent times, there's been a lot of work in trying to understand research and its impact. We know we've all been educated the fact that randomized clinical trials are the gold standard for research, right? And as of 2014, there's 18,000 plus randomized clinical trials published each year, with tens of thousands of other clinical studies. From the systematic reviews being evaluated in 2011, we report not having enough evidence to effectively inform clinical decision makers for providers and patients. So from a quantitative standpoint, there's a gap. We know there's a gap. This quote by Cochrane in 71 kind of stands out to me when I think about where the gap is and why we need pragmatic trials. Between measurements based on RCTs and benefits in the community, there's a gulf which has been much underestimated. Oops, I went too far for you guys. Sorry. A great example of when I think of pragmatic trials, they can be applied to any intervention that you're assessing. My mind automatically goes to complex interventions. And the various definitions for complex interventions, what you may think, the PPAC to me is a great example of a complex intervention being evaluated in a pragmatic trial. So it's the pain program for active coping and training. This trial is taking a pain program for patients that are suffering from chronic pain on opioids to treat that pain, and they're taking primary care practices and they're adapting and integrating different modalities of care. So behavioral therapy, physical therapy, medication consultations from pharmacy. So there's so many different modalities that need to work together to help provide the care and enable the patients to improve their pain and find different treatment options outside of opioids. As you can see here, they have an initial referral process, and then they go through a comprehensive intake process, and then they go through a primary care physician consult. And then their avenues of care can change based off what the care needs are that specific patient, what things work well for them, what are their specific needs. Within a dynamic primary care setting, there's a lot of moving pieces. And when you're thinking across health systems and different care sites, the avenues of what they're going to have available to them and how they're going to work, what's their EHR system, what's their process for staffing support, there's different regulations by states on who can do prescriptions. These all things would have to be slightly different to meet the needs of each practice to make this work. And so the pragmatic trial allows them to assess that within those varied settings. Now that I got into a little bit of history and why, I'm going to talk about design issues. When we're thinking about our standard efficacy trial, we have kind of a checklist. At least I like checklists. So I think about things that I need to have set out and understood before my trial can start. Of course, you always start with your aim and hypothesis. What is my intervention of interest? But you have your power calculation. So how many patients do I need to recruit? What's my eligibility criteria for those specific patients? How am I going to randomize them? And what criteria am I going to be randomizing? Well, how am I going to recruit them? Am I going to have study coordinators in the clinics themselves? Am I going to be contacting by the phone, etc.? And how am I going to get the data of interest to assess my outcomes of interest? These are all things that we need to decide and determine before the clinical trial starts. So Dr. Leslie Curtis on the NIH Collaboratory, one of her training videos, explained pragmatic trials as on a spectrum. And I like this idea of it, kind of the spectrum, from efficacy trials all the way up to pragmatic trials. When I think about them, I tend to think about them as a scale. Every decision I'm making, I'm trying to balance between what is feasible within the study, what are my resources, how can this be done, am I still avoiding potential contamination issues, am I not inserting any potential bias, and whether I'm doing this within an efficacy trial or a pragmatic trial, I'm still having all the same considerations. I'm still thinking through these issues. It's just I've kind of widened my perspective on how I can do this and what my main aim is at the end. A nice tool to help you think through these is the Persist tool, where you have here a scale for these specific items and you rate it. Let's see, I've lost my numbers. There we go. From a 1 being something that's more explanatory, all the way up to 5 being more pragmatic, trying to understand what your audience you're reaching, how are you assessing these, how are you thinking through these things. So efficacy trials intuitively address the efficacy of the intervention. So does it do what it's intended to do? Does it treat, does my smoking cessation behavioral intervention actually stop people from smoking, right? Within the context of pragmatic trials, this view needs to expand. And one of the key areas, now we should always be thinking about stakeholders, but since we're going outside of just that clinical box, we're going into more of an expanded view, as our keynote had spoken this morning. Engaging these key stakeholders early on and often is a very important part. Assessing what outcomes, how do their practices work, what things do they need to actually make this a part of their practice, and from an administrative support, what information do they need? Do they need some kind of return of investment analysis? What does that mean? What is important to them from that cost analysis, from the patient perspective, and so forth? So going back to that kind of cooking analogy, you can't actually plan that huge family reunion dinner without knowing what the needs are and how everything's going to work, so you can plan accordingly. One of the key stakeholders, now in all clinical trials, we should be taking patient perspective and having patient champions as part of our trials and planning and understanding. And this is true as well in pragmatic trials. About 2 years ago, I attended a conference, and there was a research group as well as a patient champion who both spoke about their combined research together and their different views on how it worked out. And it was a pleasure to watch because they definitely had made an amazing team. But the impetus behind this was there is a trial that was conducted, the Scott trial, for patients with scleroderma being treated with stem cell. There was a stem cell research project specifically. And the project itself was looking for events-free survival. They only met a third of their research recruitment goals on this study. So 75 patients of the 200 plus that they wanted to recruit. The research group of interest then kind of looked at this study that was conducted and they thought, how can we improve on this? What is important? Why weren't these patients engaging in this study? And so the next step they did is they engaged a patient partner, a champion. They conducted focus groups with patients for input. They realized that a lot of the engagement previously done with a specific group had not been done in a way that was ideal for patients. It was not convenient for them to coming out to the hospital, making different focus group appointments was really hard for them. And so they changed their model so it was more convenient for the patients and they got more engagement. They got a lot of input on what outcomes of interest were important to them. And so they redesigned the study. Specifically, one of the key things that they changed were the outcomes of interest. And they conducted it again. And this time we're able to successfully recruit the required patient population. The engagement with the patient went on to write an article of interest speaking to the relationship and what worked well. Is this article I have referenced right here, which is a nice kind of speaking point of how to partner with them. When you think of the research you do on a daily basis, think of somebody that you partnered with, whether it be a study coordinator, a research assistant, a statistician perchance. And as you've worked alongside of them, think about how your communication has improved, how you've learned from them and they've learned from you. Your statistician now understands your disease, they understand your outcomes of interest, and you become more effective, better communicators, and your work is more streamlined. That is also what we should be looking for within our patient relationships as well. How can they become a part of our research to kind of widen that voice and help us become more effective and knowledgeable? This is a clip of kind of a schematic of how healthcare systems are set up from a level perspective. It's from Cook et al. They did a lessons learned paper on pragmatic trials. It's much more from a statistical perspective, but it still has some key items to consider and think about when you're planning pragmatic trials and some of the issues around these types of trials. But when you're looking at this, you think to yourself, okay, so I'm going to randomize a specific level. Typically I randomize at the patient level, but this time maybe I can't put my intervention at that level. And how the levels interact in the patients aren't necessarily, even though this seems like a big schematic, aren't always as direct as you would think. And understanding the relationships between these and how staff work and share information is a really key component. So for instance, I had a study we were doing where we were looking at training and team communication dynamics for clinical care teams within primary care settings. And so there was a training for leadership among these care teams that would help improve team-based communications, which would hopefully then improve patient satisfaction, improve workflow, so forth. When we were trying to decide what level to randomize at, we realized that we were having overlap of people within teams within a clinic. So certain administrative staff, certain leadership staff as well would go across teams, which means that there was a problem with randomization at that level. But then if we went to other clinics in the area, staff was also shared. Nurses would travel between clinics as well. And so we had to start doing regional randomizations, which is just a consideration. And it was through conversations amongst the clinics that we kind of learned how they worked and what the potential issues were. So while there is no hard, fast rule that you have to randomize at a group level within pragmatic trials, you'll find that mostly pragmatic trials are done at a group level. For that, you're still thinking about it as a process of if you randomize patients at a one-to-one level, You have so many patients that get the intervention, you have so many patients that get the control. At the group level, you're just then choosing your group level, whether it be clinician, whether it be care team, whether it be site itself, or even health system, that half of your groups get the intervention, half of them do not. There's also, which I'm sure you're familiar with, but in case you are not, the step wedge design, where everybody goes from control to the intervention over time, and you randomize the order to which they cross over. They do have options for like a transition period, like some period of time where you need to kind of close out the control and maybe put in place the intervention, where you can have that as also an alternative step wedge design. The reality is these are getting to be much more prevalent within our research, that the group designs are becoming something that we standardly need to look at and assess. I put specifically this resource, this NIH Group or Cluster Randomized Trials resource webpage. If you're just getting started out in group randomized trials, it has a lot of training materials. It has a lot of references for you to think about. Also, they have a power calculation tool for you, which, yay, is free, that you can use. It's a nice learning point, and they actually had a great set of videos which talked about lessons learned of some people that are experts in the field and the issues that they ran into that I found extremely helpful. So within pragmatic trials, we're trying to understand across multiple potential health systems, working a lot within EHRs, or electronic health records, which is a great tool for us to advance our research, right? So we can maybe limit our footprint of our research on them and just help them get the intervention of interest into their practice. So things that the informatics or tools can help us with is randomization, identifying our patient cohort, collecting utilization, clinical outcomes, patient-reported outcomes, contacting patients through their patient portals through the EHR, and then also enabling access to the intervention. There's definitely interventions that are being put into play within the EHR as well to help improve patient care. A couple things to consider with these. So for patient identification, when we think about what we've done historically, we have a study coordinator, and we all know if you have a great study coordinator, they're worth their weight in gold. These people know our patient population, they understand how to identify them, they know the doctors that are interacting with these patients, they have face-to-face, and there's their added benefit for the patients too. As they hear about this trial, there's somebody right there. They can answer the questions, they can help them think through this process, right? But we also know that this is a timely process, and there's a lot of patients who maybe don't come in during our study period that would have been great candidates, but we're potentially losing out because we're only going through in-clinic visits. And so can we identify more patient populations, more patients within our population to engage them in our research, to give them a chance to broaden our demographics, to be more representative, and also hopefully meet the end of interest that we're all trying to do. There is issues with identifying this population within the cohort. Within our standard process, we have the study coordinator verify the information with the patient. There's usually validation by a clinician as well that the patient truly has the disease of interest or the condition of interest. When identifying these cohorts within the EHR, we know that there's messiness within our data. Everybody has messiness within their data, right? There's going to be potential reporting errors, incomplete data, overdiagnosis, underdiagnosis. There are groups of individuals from the observational end of things that are really trying to better understand how to accurately identify patients or phenotypes. These are resources that we should all be looking at while we're working within a disease area. Is there documentation of a better way to be more specific within our patient population to make sure that we're representing them accurately? For recruitment, there was a trial, the adaptable trial, that was trying to recruit 15,000 patients for their study, which was aspirin dosing, a patient-centric trial assessing benefits and long-term effectiveness. Before they rolled this out to the multiple health systems, they wanted to assess what way was the best way to recruit patients within for their study. And so they wanted to check out the different modes that they could potentially recruit the patients. So typical way would be in clinic, by email would be an option that they looked at, within the MyChart messaging, the patient portal, or by just paper mail. Now, when they first looked at this, for their patient portal, they had only 28% of their patient population that enrolled in it. So if you think about your entire patient population, we've cut it down to a third that are actually part of the patient portal if you were going to contact them for enrollment. Now that sounds bad. Now when I first looked at it, I was like, oh. But you also have to take into perspective of when we say our entire patient population, everybody who came in potentially to our ER for just one time, that is counted in that end. So that end is pretty inflated versus what we see in usual care. So who is coming back all the time that we would have that historical knowledge and understanding of what conditions they may have, what kind of care they have received. So why 28% is low, that the reality is that it's more than likely for their true patient population, it's a little higher. The interesting thing when you look at this, so the study coordinator had the highest percentage enrolled out of the other modes of contact, but they could only contact 339 patients, whereas by email, by chart, we're looking in the thousands. And so there's a much higher contact, and therefore they have, while the percent enrolled is low, 4%, we have 364 patients enrolled from the MyChart message versus only 57 in clinic. And so if you're trying to reach 15,000 patients, the idea of that kind of return of investment of having a study coordinator at each site contacting that many patients, you're not going to hit your end. But within the MyChart message, they have a much more likely chance of doing it. So for this study specifically, what I didn't show in this table, patients were invited from these messages to go to a website for the study. And they found that of the by email, by chart message, and by mail, that the highest return of actually going to the website was MyChart message. And so they had a lot more of volume of flow through their contact with patients. And it may not have reflected in a really high percentage enrolled, it did reflect in a higher enrollment number by contact. There's some other things to consider by like email or by email specifically is if you have a patient's email on chart within your EHR system, you don't know if that's a private email and whether or not other people could potentially be accessing it. I think I'm kind of getting close on time. So that would be something to consider. Well, it actually works out fine. I'm going to skip these real quick and just go into my conclusion. Thank you, Bethany. So I have just touched on some concepts and items to consider when thinking about these trials. Resources, I provided a list of different references and resources you can use in designing your trials as well and thinking through these considerations. Make sure you are engaging your stakeholders early and often. This is not a common practice in efficacy trials and should definitely be changed. But pragmatic trials, it's really key if you want to be successful. Also, one thing to consider within pragmatic trials, which we don't really touch on, is what footprint you have. Is your research going to be very heavy and burdensome on the practice itself? And is there any way to kind of lighten that load and still understand and get at your research aims? Thank you.
Thank you so much, Megan. Your slides are on the website, and there'll certainly be plenty of other opportunities to learn about pragmatic trials. So thank you so much. This room will be closing in just a moment, and I invite you all to go pick one of the two concurrent sessions that's happening right now, starting in about a minute. There's two options. One, if you want more on stepped wedge, you can go to Dr. Lee's presentation. And if you want to learn about implementation strategies and more on stakeholder engagement, you can tell it's a common theme throughout this conference. You can go to Dr. Perez-Hola's presentation starting right now as well. Thank you, everyone. See you over there.